ever stop to think about how your body just instantly kicks into gear when you start sprinting?
Yeah. Or how something tiny like pollen can set off this like whole body reaction.
Exactly. It's that incredible ability for rapid change we're diving into today. Specifically, we're looking at adrenergic agonists, these key players in those really fast responses.
Right. And the material we've got here really unpacks them for us. You know, what they are, the fascinating ways they interact with our systems.
And why they're so vital in, well, a whole bunch of medical situations.
Exactly. We've got classifications, how they work, their uses, even potential side effects laid out.
So think of this as your kind of express route to understanding adrenergic agonists.
Right.
Our mission here is to pull out the most compelling and important bits from these sources.
Get the essentials, the types, the mechanisms, the real-world impact, what to watch out for.
Yeah, give you a solid grasp without drowning you in, like, super technical jargon. Okay, so where does this amazing responsiveness even begin? The foundation.
It really all stems from a fundamental communication network in our body. Adrenergic transmission.
Adrenergic transmission. Okay.
Yeah, it's how our nervous system uses specific chemical messengers, neurotransmitters, to send signals zipping around. And these agonists, they essentially tap into this rapid signaling system.
Right. And who are these messengers doing the rapid signaling?
They're part of a family called catecholamines. And how they're made is actually a pretty cool step-by-step process. It all starts with an amino acid, tyrosine.
Okay.
The sources show it nicely. Tyrosine gets converted to dopa, then that becomes dopamine, then noradrenaline. People often just say NA for short.
NA, right.
And finally adrenaline. But here's an interesting bit. While noradrenaline is mostly made right there at the nerve endings, adrenaline is specifically synthesized in the adrenal medulla. That's part of your adrenal gland sitting on top of the kidney.
Got it. So we have this production line ending with noradrenaline ready to send a signal. What happens next? How does it get the message across?
So this noradrenaline is stored in tiny little sacs, vesicles, inside the nerve endings. When a nerve impulse comes along, boom.
Okay.
These vesicles release the noradrenaline into this tiny gap between the nerve cells. It's called the synaptic cleft.
Synaptic cleft. Right.
And that's where the action starts. The NA floats across and can bind to receptors on the next cell.
Okay, but how does the body stop these signals? You can't just have them firing off constantly, can you? It needs an off switch, right?
Absolutely. A very efficient one, in fact. The sources point out this really effective two-pronged approach. The main way, handling maybe 80% of it, is called reuptake.
Reuptake?
Yeah, feel of it like a tiny vacuum cleaner or maybe a recycling system. It just sucks the noradrenaline back into the nerve ending it came from.
Ah, okay. Ready to be used again or broken down.
Exactly. And the other 20%, that gets handled by enzymes. You've got MAO monoamine oxidase and COMT, catechol-methyltransferase.
And MAO and COMT. Kind of a mouthful.
Yeah. They act like chemical scissors. They just chop up the noradrenaline molecules that are left hanging around.
So the signal stops pretty quickly.
Very quickly. That efficient reuptake especially is crucial for how precise and rapid these responses can be.
Okay, so NA is released, does its job, then gets vacuumed back up and chopped down. You mentioned receptors, the landing pads. What are the key ones?
Exactly. The receptors are like docking stations on the cells. They're what allow NA and similar drugs, the agonists, to have all these different effects. The sources detail 5 main types: alpha-1, alpha-2, beta-1, beta-2, and beta-3.
5 types, okay.
And each type is mostly found in certain parts of the body and triggers specific actions when activated.
All right, let's take them one by one. Alpha-1, where are they and what do they do?
Alpha-1 receptors. You find them mainly on blood vessels and in the iris of your eye.
Okay.
When they get activated, they cause vasoconstriction. The blood vessels tighten up, and mydriasis.
Mydriasis, pupil dilation.
Exactly, pupils get wider. So think about it. Tighter blood vessels mean higher blood pressure.
Yeah, makes sense.
And wider pupils let more light in, maybe sharpening vision, useful in, say, a fight-or-flight situation.
Okay, clear connection there. What about alpha-2 receptors then?
Alpha-2s are fascinating. They have this kind of self-regulating job. They're mostly found presynaptically.
Meaning on the nerve ending that released the NA in the first place.
Precisely. So when noradrenaline binds back to these receptors on the cell that released it, it actually signals that cell to release less NA.
Oh, like a negative feedback loop.
Exactly. It's a built-in brake, keeps the system from going overboard. Really elegant, actually.
The volume control, yeah. Very neat. Okay, moving on to the betas. Beta-1.
Beta-1 receptors, think heart and kidneys primarily.
Heart and kidneys, okay.
Activation here ramps up the heart. increases heart rate, and also how forcefully it contracts. In the kidneys, it triggers the release of renin.
Renin. That's involved in blood pressure regulation, isn't it?
Absolutely. So if your blood pressure drops, activating beers helps bring it back up, stronger heartbeat, plus hormonal changes triggered by renin.
It all connects. Okay, what about beta-2 receptors?
Beta-2s are mainly found in the lungs and the liver. Big players there.
Lungs and liver, what do they do?
In the lungs, activation leads to bronchodilation. The airways open up, relax, and widen.
Crucial for breathing, especially in something like asthma.
Exactly. And in the liver, beta-caudabation stimulates glycogenolysis.
Glycogenolysis, breaking down stored sugar.
Yeah, breaking down stored glycogen into glucose, which is then released into the blood, gives you a quick energy boost when you need it.
So open airways and fast fuel. Makes sense. And the last one, beta-3.
Beta-3 receptors are mostly in adipose tissue, fat tissue.
Okay, energy related again.
Yep. Activating them triggers lipolysis, the breakdown of fats for energy. It's another way the body mobilizes its energy reserves. Still being researched, but definitely part of the energy picture.
Okay, wow. So we've got the signaling system, release, action, shutdown, and the targets, these different alpha and beta receptors doing specific jobs all over the body. Now, how did the drugs, the agonists, fit in? The sources classify them, right?
They do. There are basically three main ways these adrenergic agonists are grouped based on how they actually work, their mechanism of action.
Okay, what are the categories?
You've got direct acting, indirect acting, and mixed acting agonists.
All right. Direct acting first. How do they operate?
Direct acting ones do exactly what the name suggests. They bind directly to the adrenergic receptors and switch them on. They basically mimic what our natural catecholamines like noradrenaline or adrenaline do.
Like a key fitting straight into the lock.
Perfect analogy. And this group itself has subgroups. You have the catecholamines, adrenaline, noradrenaline, isoprenaline, dobutamine are examples. And then non-catecholamines like phenylephrine, which we mentioned, targets aryl receptors selectively, or salbutamol, which goes for Velvius receptors. Very specific keys.
Okay, so targeted action. What about the indirect acting ones then? They don't hit the receptors directly.
Nope. Indirect acting agonists work by boosting the effects of the noradrenaline that your body has already released. They don't interact with the receptor itself.
How do they boost it?
The classic example given is amphetamine. It works in two main ways. It makes the nerve endings release more noradrenaline, and it also blocks that reuptake mechanism we talked about.
So more NA gets released, and it hangs around that synaptic gap for longer.
Exactly. More NA, staying active longer, means a stronger, more prolonged effect on the receptors, but indirectly.
Got it. More like turning up the volume on the body's own signals. And the third type, mixed acting.
Mixed acting, yeah. As you'd guess, they do a bit of both. They can directly stimulate some receptors and also encourage the release of more noradrenaline.
A combo approach.
Right. Ephedrine is the key example here. It has both direct and indirect actions going on.
Okay, this framework really helps understand how these different drugs can have such varied effects. Let's make it more concrete. The sources highlight some key drugs. Where's a good place to start seeing the real-world impact?
Adrenaline is a great one to start with because it's non-selective. It hits pretty much all the main alpha and beta receptors.
So it is a bit of everything we just talked about.
Pretty much. The sources even use a handy mnemonic, the ABCDEs of adrenaline.
Ooh, I like mnemonics. Okay, lay it on me. ABCDEs.
Right. A is for anaphylactic shock, severe allergic reactions. Adrenaline is the absolute first-line treatment, and crucially, it's usually given as an intramuscular injection, like an EpiPen.
Okay, A, anaphylaxis. Got it. B.
B is for bronchial asthma. In a severe acute attack, its achial effects, the bronchodilation, can be life-saving.
C.
C is for cardiac arrest. It can help stimulate a stopped heart, part of resuscitation protocols.
Yeah.
D is for delaying local anesthetic absorption. If you mix a little adrenaline with the local anesthetic, say at the dentist, the vasoconstriction it causes keeps the anesthetic right where you injected it for longer, making the numbing effect last.
Clever. Okay, and E.
E is for epistaxis control. That just means stopping severe nosebleeds. Again, vasoconstriction helps clamp down the bleeding vessels.
Wow. A, B, C, D, E,
Yep.
anaphylaxis, bronchial asthma, cardiac arrest, delaying anesthetic, epistaxis. That really covers some critical situations.
It really does. It's a powerful, powerful tool in emergencies.
But with that power, I imagine there are downsides, things to watch out for.
Oh, definitely. Because it hits so many targets, the side effects can be significant. You can get tachycardia, a really fast heart rate hypertension, high blood pressure, arrhythmias or irregular heartbeats, even tremors.
Right.
And you have to be careful. It's generally contraindicated, meaning you shouldn't use it if someone already has severe hypertension or maybe angina, chest pain, because it could make those worse.
Yeah, really underscores its potency.
Okay.
What's another key example the sources pull out?
Let's look at the selective guys. Selective Voigt's agonists, like salbutamol.
Salbutamol, that's the common asthma inhaler drug, right? Ventolin.
Exactly. As we said, Voigt's receptors are mainly in the lungs, so salbutamol's primary job is bronchodilation, opening up those airways. It's a cornerstone of asthma management.
Makes sense. Does it do anything else?
It does have some other effects. It can relax the uterus, which is sometimes relevant, and it can cause a temporary drop in potassium levels in the blood, something to be aware of.
How is it usually taken? Just inhalers?
Inhalers are most common for asthma maintenance or mild attacks. But for more severe situations, it can also be given orally as a liquid or tablet or even intravenously directly into the vein.
And side effects for salbutamol, similar to adrenaline.
Somewhat, but generally milder because it's more selective. Still, tremor is quite common, sometimes a bit of tachycardia, and that potential for low potassium hypokalemia, especially with higher doses.
Okay, so a more targeted tool for breathing problems.
Yeah.
Now, what about the Avigia agonists? Phenylephrine was the example.
Right, phenylephrine. Selectively hits our receptors. Remember what they do?
Vasoconstriction and pupil dilation.
Exactly. So that vasoconstriction is why it's used as a nasal decongestant. You find it in lots of cold remedies and nasal sprays.
It shrinks the swollen blood vessels in your nose.
Precisely. Reduces that stuffy feeling. It's also used in eye drops to dilate pupils for eye exams and sometimes intravenously to treat low blood pressure, hypotension, by tightening up blood vessels systemically.
But I feel like I've heard warnings about nasal sprays.
You probably have. There's a risk of rebound congestion if you use phenylephrine nasal sprays for too long, like more than a few days.
Rebound congestion.
Yeah, when you stop the spray, the congestion can actually come back worse than before. It's quite common and frustrating. And because it raises blood pressure, you need to be cautious with systemic use.
Good to know. Okay, now dopamine seemed really interesting in the notes, the whole dose-dependent thing. How does that work?
Yeah, dopamine is fascinating pharmacologically. Its effects really change depending on the infusion rate, the dose you give.
So different doses hit different receptors.
Essentially, yes. At low doses, say under 2 micrograms per kilogram per minute, it mainly hits specific dopamine receptors called D in the kidneys. This actually causes vasodilation there, improving blood flow to the kidneys.
Okay, low dose, kidney help. What about moderate doses?
Moderate doses, maybe 2 to 5 mics per kilo per minute, you start seeing more baroreceptor activation.
Beta 1. That's the heart.
Right. So you get cardiac stimulation, increased heart rate, stronger contractions, helping the heart pump better.
And then high doses.
At high doses, over 10 mics per kilo per minute, the otter effects start to dominate.
Alpha 1, vasoconstriction again.
Exactly. So now you're getting widespread blood vessel tightening, which significantly raises blood pressure. It's like a multi-tool where the effect changes based on how hard you press the trigger.
Wow. So you can fine-tune the effects by adjusting the drip rate. That's incredibly useful. What's it mainly used for clinically then?
Well, because of this variable action, it's really valuable in treating shock, different kinds, like cardiogenic shock, where the heart isn't pumping well, or septic shock, where blood pressure plummets due to infection.
Because you might need to support the heart and raise blood pressure and maybe help the kidneys, depending on the situation.
Precisely. You can tailor the dose to target the most pressing need, or use moderate doses to try and get a balance of effects. It's a critical care drug.
Really highlights the complexity and elegance of these systems. Okay, let's quickly circle back to the indirect agents, amphetamine.
Right. As we covered, it works by pushing out more NA and blocking its reuptake. Clinically, it has uses in things like narcolepsy, excessive daytime sleepiness, and ADHD.
But it comes with risks, right?
Big time. Significant risks like insomnia, dependence, addiction potential. Its use needs very careful management and consideration.
Understood. And ephedrine, the mixed acting one.
Ephedrine, yeah. Doing a bit of direct receptor stimulation and boosting NA release. It's often used to manage hypotension, low blood pressure, particularly in specific settings like during spinal anesthesia, where blood pressure can sometimes drop quite suddenly.
Okay, so we've seen a good range of these drugs in action. But what about the dangers, the broader picture? The sources mention adverse effects and, crucially, drug interactions.
Absolutely vital to consider. We've touched on some side effects like high blood pressure, fast or irregular heartbeats, anxiety, tremors. These pretty common themes, especially with less selective agents, because you're stimulating the cardiovascular system and the central nervous system.
Makes sense. And the interactions. What are the big warnings?
The sources flag a couple of really critical ones. First, MAO inhibitors. Those are a class of antidepressants. If you combine MAO inhibitors with certain adrenergic drugs, especially decongestants found in cold meds, you risk something called a hypertensive crisis, a sudden, potentially life-threatening spike in blood pressure.
Why does that happen?
Because the MAO inhibitors stop the breakdown of NA, and the decongestant might increase NA release or mimic it. So you get this huge overload of adrenergic stimulation. Very dangerous.
Okay. MAO inhibitors plus decongestants, bad news. What's the other major one?
Beta blockers and adrenaline. Beta blockers, as the name says, block beta receptors.
Right, often used for high blood pressure or heart conditions.
Exactly. So if someone on a beta blocker is given adrenaline, say in an emergency, the beta receptors are blocked, but the alpha receptors aren't.
So you only get the alpha effects of adrenaline.
Precisely. You get what's called unopposed alpha stimulation, which means intense vasoconstriction from the alpha-1 effect, potentially causing a very dangerous rise in blood pressure.
Wow. These interactions really highlight why knowing a patient's full medication list is so incredibly important.
Absolutely critical. Always need a thorough medication review.
Okay. The sources also distilled some clinical pearls. Quick takeaways for practice.
Yeah, just reinforcing some key messages. Number 1, adrenaline IM intramuscular is the go-to first-line treatment for anaphylaxis, non-negotiable.
Got it. What else?
Salbutamol inhalers are the standard for quick relief in asthma. Dopamine's key role in treating shock, using those dose-dependent effects we discussed. And that caution about using nasal decongestants like phenylephrine for too long because of that rebound congestion risk. Practical advice.
All right, that rebound effect sounds really annoying. Okay, so just to quickly wrap up the main points, we've got these adrenergic agonists, some acting directly on receptors, others boosting our own noradrenaline.
Or a mix of both.
Right, and they have these crucial roles in emergencies like anaphylaxis, asthma, shock.
But we always need to be mindful of side effects, especially on the heart, and things like electrolyte changes, like potassium with salbutamol.
And those critical drug interactions.
Absolutely. Understanding the specifics, which receptors they hit, how they work, the potential downsides is just essential for using them safely and effectively.
This has been a really, really insightful deep dive. We've gone from the basic nerve signals right through to specific drugs and their uses and risks.
Yeah, it's a complex but fascinating area of pharmacology.
It really is. And, as we wrap up, thinking about how precisely these agonists can tweak our body's own rapid response systems, makes you wonder, doesn't it?
Wonder what?
Well, what are the bigger implications as we get better and better at targeting these pathways, for therapy? Could this lead to even more personalized, maybe even genetically tailored treatments down the line?
That's a profound thought. The potential to fine-tune these incredibly intricate systems. Yeah, it opens up huge possibilities for the future of medicine, for treating disease, maybe even enhancing well-being. Definitely something to ponder.
Gives you something to think about, for sure.